All right. All right. I think we are live. Am I audible and visible? Students, can you comment and let me know? Yes. Hello, everyone. Good evening. Hello. Yes. Am I audible? Good evening. Good evening. Hi. आवाज़ आ रही है मेरी तो बता दो. ओके, ग्रेट ग्रेट, ठीक है, वंडरफुल, ठीक है. सो गुड इवनिंग एवरीबडी. आई एम डॉक्टर प्रवीण त्रिपाठी. आई एम अ साइकेट्रिस्ट एंड आई टीच साइकेट्री. So yes, good evening everybody. Hi, hello, good evening. So let us try to use the next 60 to 90 minutes. PDF अभी कुछ बोलने तो दो भाई. पहले PDF कैसे दे सकता हूँ मैं आपको. चलो वेट करो. So let us try to use the next 60 to 90 minutes to cover as much as we can in psychiatry. We'll be focusing on covering the important topics and some of the MCQs that have been asked from these topics. I'll keep on flagging the MCQ that has been asked from particular topic or particular point. All right, चलिए start करते हैं. We'll start with something very basic. A lot of questions have been asked from this word MSC. MSC, what is MSC? Mental Status Examination, right? So please remember that the clinical examination in psychiatry is called as MSC. So basically what they do is in the exams they will ask you the clinical examination in psychiatry is called as, and they'll give you option MSC, MMSC. Say they gave an option MSC. The second option was given as MMSC. Say PSC, DSC. Your answer would be mental status examination. ठीक है, मेंटल स्टेटस एग्जामिनेशन. ये क्या होता है? व्हाट इज MMSC? MMSC क्या होता है? मिनी मेंटल स्टेटस एग्जामिनेशन, MMSC, राइट. महक इज सेइंग इको आ रही है. आवाज साफ नहीं आ रही क्या? कैन यू हियर मी प्रॉपरली? एक काम करो, हाँ क्या कर रहे हो, तो ऐसा गेट खोल दो तो इको आनी बंद हो जाएगी. हाँ, सो MMSC इज वेरी राइट, मिनी मेंटल स्टेटस एग्जामिनेशन. नाउ प्लीज टेल मी, दिस क्वेश्चन हैज बीन आस्क्ड मल्टीपल टाइम्स इन द एग्जाम्स. व्हाट इज MMSC यूज्ड फॉर? It is a screening tool for which disorder? It is a screening tool for which disorder? Yes sir, echo. Yes, echo is there but can manage. थोड़ा echo है सर. eco friendly हो गए हम लोग. echo कैसे कम होगी भाई सर? echo वॉइस नॉट क्लियर. अब ठीक है, बेटर नाउ, ऑल परफेक्ट नाउ. ओके, सही है, ठीक है, परफेक्ट हो गया. चलिए लेट्स गो बैक टू दिस. हाँ, MMSC इज अ स्क्रीनिंग टूल फॉर व्हाट? बेटर आंसर इज डिमेंशिया. ऑल्दो MMSC कैन बी यूज्ड फॉर delirium also, but the better answer is dementia. Now sometimes the question comes in the exam, what is the cutoff when we say that MMSC screening is positive? So the total score for MMSC is 30, and if a patient scores less than 24, then we say that screening is positive. Patient probably has dementia. याद रखिएगा, dementia, it is a screening tool for dementia, and a score less than 24 is screening positive. All right, important question. All right, so now let's talk about what are the components of MSC. The first component is affect. What does affect stands for? What do we mean by affect? Affect basically means emotions. Affect means emotions. Now there are two questions that are asked from this topic. The first question is, which area of the brain generates the emotions? And the second question is, which area of the brain regulates the emotions? बताइए, which area of the brain generates the emotions? MCQ है. Answer is, ऊपर चला गया क्या? Answer is limbic system. The area of brain which generates the emotions is limbic system. And which area of the brain controls the emotions? The best answer is frontal lobe. So which area of the brain generates the emotions? Limbic system. Which area of the brain regulates the emotions? Frontal lobe. Perfect. Most of you got it correct. यार ये एनोटेशन तो मैं डिलीट कर रहा हूँ, इसकी पीडीएफ तो आई डोंट थिंक आपको मिल पाएगी. सो सॉरी अबाउट दैट. क्लियर ऑल. हाँ, let's talk about the second component of MSc, which is perception. Now, there are two important abnormalities of perception that are asked in the exams. The first is called as illusion, and the second is called as hallucination. Illusion and hallucination. What is the difference? What happens in illusion is, it's a false perception of a real object. There is something there which is falsely perceived. For example, if I say that in my hand I see a black umbrella, it becomes an illusion. Why? There is something in my hand which is the pen, but instead of seeing a pen, I am seeing a black umbrella. This is an illusion. Typical question in the exam is, a patient is walking on a road, he mistakes a rope for a snake. What is this abnormality? Illusion. And what is hallucination? False perception in the absence of any object. कोई object है ही नहीं. There is no object. For example, if I say that I see a black umbrella in my hand, now this is a hallucination because there is nothing in my hand. If I say I see a black umbrella in my hand, this is an illusion because instead of pen, I am seeing an umbrella. Hallucination is, there is nothing in my hand, but I still say there is a black umbrella in my hand. So, presence of a real object in the absence of any object. What is the most common type of hallucinations, students? सबसे common hallucinations कौन सी होती हैं? Auditory, visual, olfactory, gustatory कौन सी होती हैं? बताइए. Which is the most common type of hallucination? Answer is auditory hallucination. The most common type of hallucination is auditory hallucination. The most common type of hallucination is auditory hallucination. Alright, let's talk about thought now. When we talk about thought, the most important thing that we should be aware of is delusion. Delusion. What is a delusion? It's a false belief. It's a false belief, firm belief. A belief that does not change even when you give evidences against it. A very important question. A very important question is, delusion is a disorder of which part of thought? Delusion is a disorder of flow of thought, form of thought, content of thought, or possession of thought. The fourth one is possession. Multiple times they have asked this question. Delusion is a disorder of flow, form, content or possession. Please इसको रट्टा मार लीजिए. ये बहुत बार क्वेश्चन आ चुका है. They have asked this multiple times. Delusion is a disorder of content of thought. You should not be making mistakes in simple questions like this. And another important but slightly controversial question is, obsession is a disorder of which component of thought? The answer is possession. For obsession, this live video will be available after the session is over. हाँ जी, आशु उपाध्याय जी रहेगा, मिल जाएगा वीडियो आपको बाद में भी. So please याद रखिए, delusion disorder of content of thought है, obsession disorder of possession of thought है. ये possession में there is some controversy, slight controversy, but please don't give importance to that controversy. याद रखिए, it's possession of thought. And lastly, Again, extremely important question. What is insight? Awareness of the illness. Awareness of the illness. If a patient say I have schizophrenia and I don't even realize that I have schizophrenia, in that case we will say my insight is absent. If I have schizophrenia and I know I have schizophrenia, in that case we will say my insight is present. So insight is the awareness of the illness. A favorite question of AIMS exam, used to be AIMS favorite, now it was asked in the INICT also. But remember, it's a very important question. Awareness of the illness is called as insight. Alright, let's come to an important question. We talked about delusions. Now there's a particular type of delusion called as delusion of misidentification or misidentification syndrome. Now, as the name suggests, in delusion of misidentification, the patient is suspicious about the identity of the individual, right? And there are two important syndromes. There are two important types. In fact, there are 4 types of delusions of misidentification, but the 2 important types are Capgras syndrome and Frigoli syndrome, right? So let's see what happens in Capgras syndrome and Frigoli syndrome. ये आप लोग जो PDF मांग रहे हैं, those who are asking for PDF, पहले एक बार प्लीज क्लास खत्म कर लीजिए, right? It would be more important. थोड़ा सुन लो. Capgras syndrome and Frigoli syndrome. Capgras syndrome. The Capgras syndrome. The patient believes that a familiar person has been replaced by a similar, इसको मैं यहाँ ले आता हूँ, हाँ ये ठीक है, इसको ऊपर ले आते हैं, ठीक है ना ये भी. The patient believes that a familiar person has been replaced by a similar looking stranger. हमें ये लाइन याद रखनी है. A familiar person has been replaced by a similar looking stranger. जैसे कि for example, a patient goes back home. A patient goes back to his house, to his home. In his home, his wife is sitting in the drawing room. Wife is sitting in the drawing room. Now, wife is a familiar person, but the patient with the Capgras syndrome will suddenly believe or will suddenly have this thought that this woman who is sitting in his house, in his home, who looks exactly like his wife, is not her wife, but somebody else who just looks like her. The patient believes that this woman sitting in my home who looks like my wife is not my wife, but somebody else, someone else who just looks like her. So the history that you get in the exam or in the patient is, the patient will go to his home and will start fighting with his wife. Why? He will say, who are you? How did you enter my house? How come you look exactly like my wife? So the history is, patient goes back home and he starts fighting with a familiar person, accusing them of being a stranger. Right? तो याद रखिएगा, in Capgras syndrome, patient fights with a familiar person. The patient is fighting with the wife, saying that you are somebody else. Frigoli syndrome में उल्टा होता है. In the Frigoli syndrome, the reverse is seen or the opposite is seen. In Frigoli syndrome, patient believes that the familiar persons are disguising as a stranger. The familiar person is disguising as a stranger. For example, so this is the example that I usually give. Say there is a patient. The patient has a delusion of persecution. The patient has a delusion of persecution and patient believes that wife wants to kill me. The patient believes that wife wants to kill me. Now the patient also starts believing that wife follows me everywhere I go. And now finally patient starts believing that wife follows me wherever I go, and so that I am not able to identify her, she changes her face. She changes her appearance and takes appearance of a stranger. So this patient is now believing that wife is following me everywhere and she is following me with the face of a stranger. So what is the history that you will get? The patient will go and start fighting with a random person. He'll say, you are my wife. You are following me. You are following me with a changed face so that I cannot identify you. So just to recapitulate, the Capgras syndrome guy, patient, fights with a familiar person, accuses them of being a stranger. Whereas Frigoli syndrome fights with a stranger, accusing them of being a familiar person. Sir, please tell any trick of these two. The only trick is remember one of these. Remember one of them and the other one is the other one. एक को याद कर लो, दूसरा दूसरा है. So आप एक काम करो, just remember the Capgras syndrome. Just remember the Capgras syndrome and just remember one thing that Sir told that Capgras syndrome patient fights with his wife, accusing her of being a stranger. एक ये याद रख लो. So Capgras syndrome वाइफ से लड़ रहा है, फेमिलियर पर्सन से. तो फ्रिगोली सिंड्रोम वाला किससे लड़ रहा होगा? नॉन फेमिलियर या फिर स्ट्रेंजर से. सो एक याद रख लीजिए, द सेकेंड वन इज द सेकेंड वन. ठीक है, बस एक याद रखना है. दिस इज सी व्हेन यू गेट कंफ्यूज बिटवीन टू similar sounding syndromes na, the only trick that really works is just remember one and remember the second one was the second one. ठीक है. So Capgras syndrome fights with whom? With the wife. Why? He says you are somebody else who just looks like wife. चलिए, let's talk about schizophrenia. All right, schizophrenia, देखिए, please remember that it is very unlikely that the examiner will ask you to make a diagnosis on the basis of criterias, right? So I would suggest that don't even try to remember the criterias. Anyways, you won't be able to remember the criteria. There are so many disorders. How will you remember the criteria of everyone, of every disorder? So it's impossible. So just remember the symptoms. 99% of the times, the examiner will ask you a question on the basis of symptoms, not on the basis of criteria. So when you talk about schizophrenia, we divide the symptoms into multiple types. The first type of symptoms are the positive symptoms, also known as the psychotic symptoms. What are the positive symptoms? Delusions and hallucinations. The two most famous symptoms, delusions and hallucinations. Positive symptoms have a positive prognosis. Positive symptoms are associated with a good prognosis. And positive symptoms respond better to medications also. It's positive, everything is positive. Good prognosis and they respond better to medications also. As far as your exams are concerned, more important are the negative symptoms. There are many negative symptoms like avolition. What is the meaning of avolition? Lack of desire for any meaningful activity. The patient does not do anything meaningful. Say the patient is a medical student. The patient would not go to college. The patient would not study. After some time, the patient would also stop taking bath. The patient would not shave, right? So all the boys in the boys hostel, some of them also have something like avolition. Then you also have what is called as affective flattening. Affect means emotions. Flattening means flat, right? Affective flattening is lack of emotional response. Typically in the clinical scenarios, we ask the patients, we ask the family members of the patients, does the patient get happy when there are festivals? Say there is Diwali, there is Eid, there is Holi. Does the patient get happy during festivals? Or does the patient get sad when something bad happens in family? The family members of patients with affective flattening say, no, he does not get happy nor he gets sad. It appears as if he is not getting impacted by anything. Anhedonia. lack of pleasure in previously pleasurable activities. Lack of pleasure in previously pleasurable activities. Things that used to make you happy no longer make you happy, right? You enjoyed watching cricket, now does not make you happy. You enjoyed watching movies, does not make you happy, right? एग्जाम पॉइंट ऑफ व्यू से दो चीज़ें हैं. सबसे इंपॉर्टेंट, नेगेटिव सिम्टम्स हैव अ नेगेटिव प्रोग्नोसिस. ये बहुत इंपॉर्टेंट है, इट्स वेरी इंपॉर्टेंट, प्लीज याद रखिएगा. एंड दे डोंट रिस्पॉन्ड टू मेडिकेशंस एज वेल. दे डोंट रिस्पॉन्ड टू मेडिकेशंस एज वेल, राइट. तो एग्जाम में क्वेश्चन कैसे आता है? द टिपिकल क्वेश्चन इन द एग्जाम इज, अ पेशेंट प्रेजेंट्स टू यू. The patient hears certain voices not heard by others. The patient is also suspicious that family members want to kill him, and the patient also becomes violent and agitated, and the patient does not have any emotional responsiveness either. Which of the following is associated with a negative prognosis? Suspiciousness, agitation, hearing voices, or lack of emotional responsiveness? आपका आंसर क्या है? Lack of emotional responsiveness. ठीक है जी. सो क्लिनिकल क्वेश्चंस ऐसे आएंगे. ऑलराइट, अपार्ट फ्रॉम दीज द थर्ड इंपॉर्टेंट वंस आर द मोटर सिम्टम्स. द थर्ड इंपॉर्टेंट ग्रुप ऑफ सिम्टम्स आर कॉल्ड एज मोटर सिम्टम्स, ऑल्सो कॉल्ड एज कैटाटोनिक सिम्टम्स. कैटाटोनिक सिम्टम्स. सो क्या होते हैं कैटाटोनिक सिम्टम्स? वन ऑफ द कैटाटोनिक सिम्टम इज स्टूपर. Stupor. What is stupor? Lack of response. Patient is not responding, and patient is usually also immobile. Patient is immobile and not responsive. Have you seen that movie मुन्ना भाई MBBS? मुन्ना भाई MBBS देखी आप लोगों ने? मुन्ना भाई MBBS. मुन्ना भाई MBBS में वो जो क्या नाम था उसका, आनंद भाई. That guy who is sitting on the wheelchair, आनंद भाई. If you look at him, that is the status of a patient with stupor. The patient is sitting on the wheelchair, does not speak, does not move, but eyes are open. Lack of responsiveness, right? And immobility. The patients usually do not say anything. Yes, Anand bhai. So this is stupor. Another symptom, catatonic symptom, is posturing. Now put a star on the posturing. It is a likely image-based question. It is a likely image-based question. The name is quite suggestive. Patient maintains a posture for prolonged periods of time. Patient maintains a posture for prolonged periods of time. Image-based question. They may give you an image where the patient is, maintaining some kind of posture. Patient is in some weird kind of posture, and then they will ask you, what is the clinical sign here? Posturing is maintenance of a posture for long periods of time. Third catatonic symptom, echolalia. ये FMG एग्जाम में आया था क्वेश्चन. This question was asked in the FMG examination. Echolalia and echopraxia. Echolalia, echopraxia. हाँ, वैक्सी फ्लेक्सिबिलिटी भी होता है, बट एग्जाम में उतना आता नहीं है. What is echolalia? Repetition of the speech. You ask the patient, what is your name? Patient responds, what is your name? You say, no, what is your name? Patient says, no, what is your name? Whatever you say, patient simply repeats it. Repetition of the speech. And what is echopraxia? Mimicking of the behavior, repetition of the behavior. So in echopraxia, usually how we test it? Usually we go to the bedside of the patient and we start scratching our forehead. If the patient also starts scratching the forehead, तो वो echopraxia हो गया. Echolalia, repetition of speech. Echopraxia, repetition of the behavior. Treatment. So if we talk about the treatment of schizophrenia, basically we use antipsychotics. And we have got two classes of antipsychotics. We have got first generation antipsychotics and we have got the second generation antipsychotics, also known as typical antipsychotics, also known as atypical antipsychotics. Associated with more EPS, more extrapyramidal side effects, associated with less extrapyramidal side effects. associated with less metabolic side effects, associated with more metabolic side effects. ये metabolic side effects क्या होते हैं? Weight gain, increased sugar level, dyslipidemia. ठीक है? Can anybody tell me which antipsychotic is associated with minimum EPS? Which particular antipsychotic has got minimum EPS? सबसे कम एक्स्ट्रा पिरामिडल साइड इफेक्ट कौन सी एंटीसाइकोटिक करती है? बताइए. Which antipsychotic is associated with minimum EPS, minimum extrapyramidal side effects? Abhi Andrew says aripiprazole. I mean, it is one of the antipsychotics with minimum EPS, but not minimum. Isha says clozapine. Farah says clonazepam. Risperidone, haloperidol. Jo mana hai bol do. No negative marking. Now everybody is giving the right answer. Yes, the answer is clozapine. Good. All our students are well read. Very good. अपने आप को give yourself a pat at the back जिसने सही बताया. Clozapine has got the minimum extrapyramidal side effect. Second question. Kingfisher is wrong. दुबे जी सुधर जाइए. ठीक है. थायरोइडाजिन जो लोग बोल रहे हैं ना, थायरोइडाजिन इज द typical antipsychotic with minimum EPS. Overall, it is clozapine. Achha, second question. Which antipsychotic is associated with maximum weight gain? Which antipsychotic is associated with maximum weight gain? ये बताइए. Which antipsychotic is associated with maximum weight gain? Should I give you 4 options? No. The answer is clozapine. Again, antipsychotic with maximum weight gain is also clozapine. अच्छा, एक third different question. Which antipsychotic is known to have anti-suicide properties? In fact, the only antipsychotic with anti-suicide properties. ये बताइए. The only antipsychotic with anti-suicide properties. The answer is अगेन क्लोजापिन. मैंने 3 क्वेश्चन पूछे हैं. द एंटीसाइकोटिक विद मिनिमम एक्स्ट्रा पिरामिडल साइड इफेक्ट, क्लोजापिन. द एंटीसाइकोटिक विद मैक्सिमम वेट गेन, क्लोजापिन. द एंटीसाइकोटिक विद एंटी सुसाइड प्रॉपर्टी, अगेन क्लोजापिन. राइट. आंसर टू ऑल दीज 3 क्वेश्चन इज क्लोजापिन. चलिए. अच्छा, व्हाट इज द ड्रग ऑफ चॉइस फॉर कैटाटोनिया? व्हाट इज द ड्रग ऑफ चॉइस फॉर कैटाटोनिया? If a patient presents with catatonia, stupor, posturing, echolalia, echopraxia, in that case you would not mark antipsychotic as the first choice. The answer, the drug of choice for catatonia is intravenous lorazepam. Intravenous lorazepam is the drug of choice for catatonia. If a patient comes in stupor, posturing, you give intravenous lorazepam. ये बहुत इंपॉर्टेंट है. दिस इज अ वेरी इंपॉर्टेंट टॉपिक. फिर छुप गया. हाँ जी. कैन यू सी द स्क्रीन? आई होप यू कैन सी द स्क्रीन. राइट. So we are talking about different types of EPS. A lot of questions are asked from this. So Kashif, ECT भी सही बोल रहे हो आप, you are right. But I mean, we say that intravenous lorazepam and ECT, both of them are first line. But if you have to pick one, you will go with lorazepam. ठीक है. Now let's talk about the different types of extrapyramidal side effects. Very important topic. A lot of questions are asked from this topic. The first one is acute dystonia. Typically the question would be, a patient comes to you, patient is aggressive, violent, agitated. You give him an antipsychotic. Maybe you give him an injectable. You give a injectable antipsychotic, and suddenly there is uprolling of eyeballs. suddenly there is up-rolling of eyeballs. पेशेंट आया, एग्रेसिव था, आपने एंटीसाइकोटिक इंजेक्टेबल दे दिया. अ पेशेंट कम्स टू यू, ही वाज एग्रेसिव, यू गिव एन IV, say you gave IV HPL, haloperidol. A couple of minutes later, there is up-rolling of eyeball. What is it? It is acute dystonia. The earliest side effects of antipsychotics is acute dystonia. Or patient comes, a sudden up-rolling of eyeballs would be called as oculogyric crisis. Oculogyric crisis. Or the patient comes to give antipsychotic, patient suddenly has torticollis. Earlier side effect. How will you treat it? By giving a parenteral anticholinergic. You give parenteral anticholinergic. उसको intramuscular promethazine दे दीजिए. The patient will immediately respond to it. This is something which happens in the emergency very often. You start the patient on an antipsychotic. Even oral antipsychotics can cause it. There is suddenly uprolling of eyeballs. Now the family members get very scared because it looks very scary. And then the patient comes to emergency. You give him promethazine, and within seconds the patient is better. Question of this year: acute akathisia. You start the patient on antipsychotic. Now the patient has restlessness. The patient feels restless. And objectively also there is restlessness. Objectively how? The patient cannot stand. The patient keeps on standing on one leg, then on the other leg. One leg, other leg. He keeps on fidgeting. Right? Patient typically आके जैसे कि पैरों में बेचैनी है. There is so much restlessness that I cannot stand still or sit still. This is akathisia. It is the most common side effect. Most common side effect of antipsychotics. Drug of choice, beta blockers. Drug of choice, beta blockers. You can also give benztropine, कोई issue नहीं है. You can give promethazine, benztropine, कुछ भी दे दीजिए. The lethal, a side effect which can be lethal is NMS, neuroleptic malignant syndrome. Lethal side effect of antipsychotics. 3 things would be given in the exam. You start the patient on antipsychotic. If the patient develops NMS, there would be elevation of temperature. There would be muscle rigidity. The muscles would start getting damaged. So the creatinine phosphokinase starts increasing in the blood. The serum CPK starts to increase. Even the myoglobin may start getting damaged. There may be myoglobinuria. And this myoglobinuria may lead to acute renal failure. That is the mechanism of death in patients with NMS. Muscle damage, myoglobinuria, acute renal failure, death. So it is very important to hydrate the patient. You want to keep the patient hydrated. If somebody asks you the drug of choice, it is dantrolene. ठीक है जी. Then अभी a couple of years back, AIMS asked this question. Tardive. What is the meaning of tardive? Tardive means long term. If you are continuing the patient on long term antipsychotic for months or years, कैसे? How does antipsychotic work? Antipsychotics काम कैसे करती हैं? What is the primary mechanism of action? So primarily they work by blocking the dopamine receptors, right? D2 receptor का blocker होता है. क्या हुआ?
साइज थोड़ा इंक्रीज
कर दो. So usually they block D2 receptors, right? If you have kept the D2 receptors blocked for a long period of time, since the antipsychotic was being given for a long period of time, sometimes the remaining receptors become super sensitive. There may be super sensitivity of receptors. If your dopamine receptors become super sensitive, it would lead to abnormal movements, tardive dyskinesia. And how will you treat tardive dyskinesia? First of all, you try to shift the patient to a different antipsychotic. Again, all of these are more common with typical antipsychotics. So if a patient is on a typical antipsychotic, you stop it. You try to move him on a atypical antipsychotic. But if they ask you specifically about the drugs, then you can use dopamine depleters like valbenazine or tetrabenazine. Valbenazine or tetrabenazine. Valbenazine or tetrabenazine. ठीक है, चलिए. All right, this is a question from INICT examination, in INICT exam. So, in schizophrenia, many a times the patient does not. हाँ ठीक है, valbenazine spelling गलत हो गई, ठीक है. Sometimes the patient, many times the patient does not have insight. Patient की insight नहीं है. Patient does not know that he has schizophrenia. So you start him on antipsychotics and the patient does not want to take antipsychotics. So there is a lot of problem with the administration of medication, poor compliance. So the typical question is, what will you do now? The patient is not taking the medications. What is the next step? So if there is poor compliance to treatment, you can start the patient on depot antipsychotics, which are basically long acting injectables. You take the antipsychotic, you give 1 month antipsychotic in single dose. And in a single visit, you give the monthly antipsychotic dose. The antipsychotic will keep on getting dissolved and it will keep on going into the bloodstream. Even if the patient is not taking medications regularly, at least the antipsychotic is now in the blood. Depot antipsychotic. And the INICT had asked this question, how do you give, what is the mode of giving or the method of giving depot antipsychotics? So we know that all the intramuscular injections are given by a Z-track technique or Z-track technique. Basically, before giving the injection, you pull the skin and the subcutaneous tissue muscle towards one side, then you give the injection and then you leave it. So when you pull it towards one side and then you give the injection, and then when you leave it, the track that gets formed is Z-shaped. So the antipsychotic cannot seep out. So just remember Z-track technique. 2 or 3 times they have asked this question in last 4 or 5 years. This is Z-track technique. बताइए क्या आंसर है इसका? What is the answer? Image based question. This was asked in one of the NEET exams. Identify the syndrome. हाँ जी, what is the answer? Is it Capgras or Frigoli? Capgras में क्या था? The patient believes that a familiar person has been replaced by a similar looking stranger. Familiar person has been replaced by a similar looking stranger. So in Capgras syndrome, the face remains the same. Whereas in this case, what we see is the person has a face and can put 2 different faces using 2 different masks. So this is Frigoli syndrome. Capgras syndrome पे तो image based question देना ही मुश्किल है, because the face remains the same. It is difficult to give an image based question on Capgras because the face remains the same. Here, the patient believes that this particular person can change the face by putting this mask or this mask. This is Frigoli syndrome. This is Frigoli syndrome. हाँ, गोली दे रहा है, फ्रिगोली syndrome. ठीक है जी. Let's talk about a couple of questions from the topic of mood disorders, starting with depression. इंडिया में निम्हांस ने एक स्टडी की थी called as National Mental Health Survey. According to it, the most common psychiatric illness in India is depression. The most common psychiatric illness in India is depression. Again, you don't have to remember the criteria. Just remember the symptoms. Symptoms like sadness of mood. Patient remains sad. Patient has loss of interest in work. Patient has negative thoughts. Patient has sleep disturbances. Patient has appetite disturbances, right? Patient has guilt. All these are the symptoms of, all of these are symptoms of depression. What is the duration criteria for depression? For how many days or for how many weeks should the symptoms persist before we can call it depression? Weight loss, yes. For how many days or weeks should the symptoms last before we can call it depression? बताइए. The duration criteria for depression, how much is it? It is 2 weeks. 2 weeks. The symptoms should stay for at least 2 weeks before we can call it depression. So out of all the negative thoughts that the patient has, 3 types of thoughts, 2 weeks answer hai, 6 months, 1 month nahi hai, 2 weeks answer hai. There are 3 thoughts which are particularly important. What are they? Ideas of hopelessness, ideas of helplessness, and ideas of worthlessness. This is called as cognitive triad of depression. Cognitive triad of depression. Right? Ideas of hopelessness, helplessness, worthlessness. What is the meaning of idea of hopelessness? The patient feels or the patient starts thinking that there is no hope in the future. Yes, it's Beck's cognitive triad. Beck's cognitive triad. Hopelessness is there is no hope in the future. Helplessness is the world is a bad place. Nobody can help me. The world is a hostile place. And worthlessness means I am worthless. I don't have any qualities. Nobody likes me. Right? Ideas of hopelessness, helplessness, and worthlessness. Why are they important? Specifically, ideas of hopelessness are associated with increased risk for suicide. Increased risk for suicide. Right? So, please remember, when we talk about the psychological theory of depression, biological theory, all of you know. If somebody asks you which neurotransmitter is involved in the development of depression, the best answer is serotonin, and even better answer is all 3, serotonin, norepinephrine, and dopamine. But they ask you more about the psychological theory of depression. Psychological theory of depression. And in psychological theory of depression, we say that negative thoughts are responsible for development of depression, and of all the negative thoughts, these 3 are particularly important. Treatment. Of course, you can give patients antidepressants. You can give the patients antidepressants, like you can give the patient SSRIs, selective serotonin reuptake inhibitors. You can give the patient SSRIs. You can give the patient TCAs, although these are the older medications, rarely given now. You can give the patient SNRIs, serotonin, norepinephrine reuptake inhibitors. You can give the patient other antidepressants called as atypical antidepressants. And apart from medications, you can also use CBT, cognitive behavioral therapy. So we talked about the psychological theory of depression, that depression is caused by negative thoughts. And how do you fix the negative thoughts? By using the cognitive behavioral therapy. Exam question: which is the most effective psychotherapy for depression? Answer: CBT. In fact, exam mein, if they ask you a question on psychotherapy, the best psychotherapy, and if you do not know the answer, and if you just have to make a guess, for most of the things, the best therapy remains cognitive behavioral therapy. For most of the disorders, CBT works the best. What is the treatment if the patient has high suicide risk? In case the patient has high suicide risk, The examiner tells you that patient has been having depressive symptoms for last 3 weeks, and 2 days back patient attempted suicide but was saved by the family members, or that the patient is having repeated suicidal thoughts. In that case, what is the treatment of choice? What is the treatment of choice? Exactly. If the patient has high suicide risk, do not even think twice. The treatment of choice is electroconvulsive therapy, ECT. Don't even think twice. ECT is the answer in this case. Yes, all of you are answering it correctly. ECT, electroconvulsive therapy. Why? ECT works very quickly. Medications will take a couple of weeks before they start working. Therapy will take a significant amount of time. Something which works immediately is electroconvulsive therapy. So nowadays, as far as the management is concerned, a lot of questions are asked from the side effects of the antidepressant. Almost every year they are asking a question on the side effect of either TCS or SSRIs. So let's talk about it. बहुत इंपॉर्टेंट है ये. इसके ऊपर जितने भी स्टार बना लो उतने कम है. Extremely important. So TCS are not so safe. TCS are not so safe because overdosage can be lethal, and you know that TCS have anticholinergic side effects. You know that TCS also block the sodium channels. So if a patient by mistake or voluntarily overdoses on TCS, what are the symptoms that you will have? Patient will have hypotension, tachycardia, altered sensorium, there may be respiratory depression and seizures. And because of hypoxia, the patient also develops metabolic acidosis. But the question is asked from this point the most. How will you treat the patient? You will treat the patient only if you would give the treatment of intravenous sodium bicarbonate only on the basis of the ECG changes. First of all, first question is, what are the changes in ECG? Apart from other things, the most important thing is the QRS interval is prolonged. Right? And second question is, how will you treat this overdosage? If the QRS interval is more than 100 milliseconds, in that case, you give the patient intravenous sodium bicarbonate. You give the patient intravenous sodium bicarbonate. Extremely important question. हर साल आता है, हर 1-2 साल में आता है. ठीक है, करेक्ट. TCA का तो पूछते ही हैं. They also ask you question on the SSRI side effects. SSRIs. So SSRIs are one of the most prescribed antidepressants. Often the first line antidepressant is SSRIs because of a better side effect profile. Usually SSRIs are tolerated very well. What are the side effects? In the initial days, patient may have some GI side effect, right? Bloating, anorexia, diarrhea, vomiting, all those GI side effects that you know of. Long term, there may be sexual side effects. Like what? There may be decrease in libido. There may be decrease in libido. There may be inability to achieve orgasm. The patient is not able to achieve orgasm. The ejaculation gets delayed. So in real clinical practice, sexual dysfunction is one of the problematic things, especially with the younger patients. They are very afraid of having sexual side effects. Although in most of the cases, almost all the cases, when you stop the antidepressants, the side effects also go away. Okay, answer me this. This delayed ejaculation, which is a side effect, it becomes therapeutic, it becomes beneficial in which medical condition? In which medical condition will it become beneficial? बताओ. हाँ जी. In which medical condition will it become beneficial? Exactly. Premature ejaculation. Premature ejaculation. So it's a side effect, but in patients with PME, it actually becomes a therapeutic thing. It becomes a good thing. SSRIs can cause sweating, they can cause vivid dreams, and weight gain is a particularly problematic side effect. ये क्वेश्चन एग्जाम में आया था, आई थिंक लास्ट ईयर और दिस ईयर ओनली इन द नीट एग्जाम. which antidepressant does not cause sexual side effect or minimal sexual side effect? Minimal sexual side effect. So mirtazapine as well as bupropion, they rarely cause any side effect, sexual side effect. They do not really cause sexual side effect. एग्जाम में आया था, नीट एग्जाम दिस ईयर, आई थिंक दिस ईयर और लास्ट ईयर. चलिए, we talked about ECT. All right, we have two types of ECT. We know that we have got direct ECT and we have got modified ECT. We have got direct ECT and modified ECT. What is the difference? In modified ECT, first of all, we use anesthesia, which is not used in direct ECT. Yes, mirtazapine is an atypical antidepressant. Yes, it's an ASA, right? Very good. Rai Arora, very good. In modified ECT, we use anesthesia and we also use muscle relaxants. So, you know that in the recent years in India, direct ECT has been banned. Direct ECT has been banned in India. In the recently passed Mental Health Care Act, the direct ECTs have been banned from India. Banned in India. Now you can give only modified ECTs. And give me this answer. Which is the anesthetic drug? Which is the drug of choice for anesthesia? Anesthetic agent of choice in ECT. What is the answer? Methohexital. Methohexital is the anesthetic agent of choice. And we already talked about CBT. You can use CBT. ठीक है जी. All right. After depression, let's talk a bit about bipolar disorder. We have got bipolar 1. We have got bipolar 2. What happens in bipolar 1? Patient may have episodes of mania as well as depression. And bipolar 2, there is no mania. Only the milder form, hypomania and depression. This classification has been recently added in ICD-11. Till ICD-10, we did not have this classification. So mania plus depression is bipolar 1. Hypomania plus depression is bipolar 2. Important question comes from the treatment of bipolar disorder. How do you treat bipolar disorder? Now this is something which has become a favorite question of the examiners. How will you treat a pregnant patient who has bipolar disorder? A pregnant female comes to you in mania. How do you treat this patient? Now, normally in mania, we can use three types of medications. We can use mood stabilizers. You know that. We can use mood stabilizers like lithium, like valproate. We can use antipsychotics. And if required, we also add benzodiazepines. Now, we want to treat a pregnant patient who is in mania. Let's talk about mood stabilizer first. If you use lithium, what can it cause? All of us know it can cause. If you use lithium, what can it cause? Of course, it can cause abstinence anomaly. What can valproate cause? If a pregnant female uses valproate, what can the child have? Neural tube defects. And similarly, if you use carbamazepine, again the baby may have neural tube defects. So first of all, which is the safest in pregnancy? The safest is actually antipsychotic. Multiple times they have asked this question. If you want to treat a pregnant female, prefer antipsychotics over mood stabilizers. Antipsychotics have very little chance of causing any kind of teratogenicity. If you use lithium, it can cause abstinence. If you use valproate, it can cause NTD, even if you give folate. And if you use carbamazepine, again it can cause neural tube defect. Another question which was asked 2 years back, which one should you not give at all? Better तो दूर की बात है, जो देनी ही नहीं है, which one you should never give? Which one is the most dangerous? बताइए, which one is the most dangerous? The most dangerous is valproate. The chances of baby developing neural tube defect are much higher on valproate than chances of baby developing Epstein's anomaly on lithium. So you avoid valproate completely. Until unless nothing else is working, you do not give valproate. So you never give valproate. This was a question in the last year. Don't give valproate. If a patient of bipolar disorder comes to you in depression, how will you treat? What is the first line treatment? You can use lithium or lamotrigine, the two mood stabilizers. And now you will answer a very important question which was asked in AIMS 4-5 years back. Which is the only mood stabilizer with anti-suicide properties? The only mood stabilizer with anti-suicide properties. बताइए. The only mood stabilizer with anti-suicide properties. Yes, Sudarshana, very good. Shelja, very good. Shweta is writing antipsychotics. Shiva, right, you are right. So lithium. The only mood stabilizer with anti-suicide properties is lithium. Now, say a patient with bipolar disorder presented to you and you did not take history properly. You thought it is normal depression. You thought it is unipolar depression or major depression. And you started the patient on an antidepressant. A patient of bipolar disorder who was in depression, he came to you for treatment. You started him on an antidepressant. What may happen? Patient may switch from depression to mania. Patient may switch from depression to mania, which is called as manic switch. Patient came to you for the treatment of depression. You gave him antidepressants directly and patient switches to mania. This is called as manic switch. So in patient with bipolar depression, you never give antidepressants alone. If at all you have to give antidepressants, you will add a mood stabilizer to antidepressant. You never give antidepressants alone. Yeah, I know my handwriting is very bad. I'm too old to change it now. Alright. Mood stabilizer plus antidepressants. In case you have to give. ठीक है जी? चलिए. Like a month back, we got this data from the National Crime Record Bureau, NCRB. The latest data of India is the suicide rate in India has reached its highest number. India has the highest ever suicide rate ever in the history of the country till we started counting it. The suicide rate in the India has reached 12 per lakh of population. What is paradoxical suicide? So patient with depression has suicidal thoughts, but he lacks energy. He is so tired that he cannot even act on the suicidal thoughts. Now you start the patient on antidepressant. The energy becomes better, but still he has suicidal thoughts. The patient has depression, he had suicidal thoughts, but there was no energy, so he was not acting on those thoughts. The patient was given antidepressants, energy improved. Energy improved, but suicidal thoughts are still there. So there's a small window. There's a small window where the suicidal risk is actually increased. After starting the treatment, it is called as paradoxical suicide. It is called as paradoxical suicide. This is as far as the MCQ is concerned. In the real world, real clinical world, this does not happen. ऐसा कुछ नहीं होता. Right? So, as long as you are doing MCQs, remember this thing. But since you are also doctors and you will be practicing in a couple of years, please remember that the chances of paradoxical suicide are like negligible, right? The decrease that the antidepressants cause, the decrease in the suicidal risk because of the effect of antidepressants is much higher than any theoretical increase in the risk of suicide, which is called as paradoxical suicide. So as far as your MCQs are concerned, remember this, but don't worry about it as far as the practice is concerned. चलिए, ये बड़ा इंपॉर्टेंट है. What are the risk factors for suicide? The most important risk factor is previous suicide attempt. Who is likely to attempt suicide in the future? Somebody who has attempted suicide in the past. Hopelessness, male sex, history of substance abuse. All of these are important. Old age. Elderly males are at particularly higher risk. All these are important risk factors for suicide. ठीक है जी. But most important is previous suicide attempt. Alright, NEET PG के एग्जाम का क्वेश्चन है postpartum blues. Postpartum blues and postpartum depression. Again देखिए, the biggest mistake you guys make is you start looking at the duration after how many days the symptoms started, and you try to make a diagnosis on the basis of it. Please don't do that. After delivery, a large number of females, almost 75%, the range is very wide. The book says 20 to 75%. Some depressive symptoms. There are some depressive symptoms, like there are some crying spells, patient feels sad, patient feels overwhelmed, patient has insomnia. All of this is postpartum blues. After delivery, mild depressive symptoms. After delivery, significant depressive symptoms. Sadness of mood. Not taking care of child. Suicidal thoughts in the mother. Thoughts of harming the baby. This is postpartum depression. Mild symptoms, postpartum blue. Severe symptom, postpartum depression. ठीक है जी. So please remember, in case they give you a significant symptom like suicidal thought or thoughts of harming the baby or significantly disturbed sleep and appetite, disturbances are significant. If they give you anything to tell you that symptoms are severe, make the diagnosis of postpartum depression. If they give you some symptoms, make the diagnosis of, sir your handwriting मस्त है. हाँ मुझे पता है भाई, insight present. ठीक है. Some symptoms, postpartum blues. Lot of symptoms, postpartum depression. Psychotic symptoms. Patient has delusions or hallucinations. Postpartum psychosis. There are only two psychotic symptoms, delusions and hallucinations. Right? Postpartum psychosis. देखो, harming baby can be in psychosis also, is usually in psychosis, but it can also be part of postpartum depression. Sometimes patients develop a delusion that the child is not mine. Right? It would go towards postpartum psychosis. Sometimes if all other symptoms of depression are given and then a delusion is added, in that case, we'll have to make the diagnosis of postpartum depression. Please don't make a diagnosis on the basis of a single symptom. Right? बाकी symptoms तो देखिए. ठीक है जी. लेट्स टॉक अबाउट ओसीडी. हर साल क्वेश्चन आता ही आता है. एवरी ईयर दे आस्क यू क्वेश्चन फ्रॉम ओसीडी. सो इन ओसीडी ऑफ कोर्स वी हैव ऑब्सेशंस एंड कंपल्जन्स, रिपीटेटिव एंड इंट्रूसिव थॉट्स. रिपीटेटिव इंट्रूसिव थॉट्स. मैं ना आई एम गोइंग टू, तुम लोग कुछ ज़्यादा मेरी हैंड राइटिंग में कमेंट कर रहे हो, तो मैं डॉक्टर स्पर्स सर की टेक्निक फॉलो करने वाला हूँ. अपेरेंटली दिस हैपेंड. डॉक्टर स्पर्स ऑल्सो हैज़ अ वेरी बैड हैंड राइटिंग एंड डॉक्टर गोबिंद टोल्ड हिम दैट इफ़ यू वांट टू टीच, स्टार्ट राइटिंग इन कैपिटल लेटर्स. उससे हैंड राइटिंग कम गंदी दिखती है. तो ऑल थ्री ऑफ अस आर फ्रॉम UCMS, तो मैं भी वही फॉलो कर रहा हूँ. सो रिपीटेटिव इंट्रूसिव थॉट्स इज ऑब्सेशन. रिपीटेटिव बिहेवियर, बट ये कैपिटल में लिखने में थोड़ी स्पीड कम हो जाती है, तो बहुत बोरिंग है यार, इतना कौन लिखेगा. मैं नहीं लिख रहा, मेरी ऐसी हैंड राइटिंग है. एक्सेप्ट कर लो, एक्सेप्टेंस में बहुत फ़ायदा है ज़िंदगी में. रिपीटेटिव इंट्रूसिव थॉट्स इज ऑब्सेशन. हाँ जी ठीक है. रिपीटेटिव इंट्रूसिव थॉट्स, इनफैक्ट रिपीटेटिव इंट्रूसिव थॉट और इमेजेस or even impulses, all of this is obsession. Repetitive behavior is विवेक सर सुन रहे हैं, विवेक सर अब क्या करें बताओ. चलो ठीक है. Repetitive intrusive thoughts is obsession. Repetitive behavior is compulsion. So for example, I get a thought that my hands are unclean, right? A thought comes in my mind that my hands are unclean. I know that my hands are clean. I know that it's a stupid thought. I know it's a senseless thought. But the thought keeps on coming in my mind again and again, again and again. I get anxious. I get uncomfortable. This is obsession. Finally, what do? I go and I wash my hands. This is compulsion. Obsession and compulsion. Right? For how many weeks the symptoms should be present before we diagnose it as OCD? पढ़ लो, मेरी हैंड राइटिंग एग्जाम में नहीं आएगी, कि क्वेश्चंस एग्जाम में आने वाले हैं. ठीक है. फॉर हाउ मेनी वीक्स शुड द सिम्टम्स बी प्रेजेंट बिफोर यू कैन डायग्नोज OCD? द आंसर इज 2 weeks. सो OCD ऑल्सो इज प्राइमरली कॉज्ड बाय abnormalities of serotonin, right? Serotonergic dysregulation is what causes OCD, and the duration criteria is 2 weeks. If you remember, this is true for depression also, primarily caused by serotonergic dysregulation, and the duration criteria is 2 weeks. In fact, the most common comorbidity with OCD is depression only, right? So आपके एग्जाम में क्वेश्चंस जो आते हैं, they are primarily asked from the treatment of OCD, from the treatment part of OCD. Treatment is extremely important. Every year they ask a question on this. We'll remember a couple of important points. All of them are MCQs as far as the treatment is concerned. First of all, the best treatment, most effective treatment is a combination of pharmacotherapy plus psychotherapy. You give both medical treatment and psychotherapy. In fact, that is true for most of the psychiatric disorders. If you have the option of giving both, for medicines also and therapy also, give both. In pharmacotherapy, what is the first line treatment? SSRIs and clomipramine. Clomipramine is a type of TCA. SSRIs and clomipramine. So will you prefer SSRIs more or clomipramine more? Will you prefer SSRIs more or clomipramine more? If you have to start a patient, you prefer SSRIs. Why? Because they have a better side effect profile. Clomipramine can cause more side effects. SSRIs are much better tolerated. So we started SSRIs. Even more important, what is the psychotherapy of choice? Very important question. The answer is exposure and response prevention, ERP. Exposure and response prevention, which is a type of CBT. Sometimes some books say type of BT. CBT is cognitive behavioral therapy, BT is behavioral therapy, right? So ERP, exposure and response prevention, is the therapy of choice. It is a type of CBT. In exam, if they give you both options, ERP also and CBT also, in that case will you choose ERP or CBT? एग्जाम में अगर दोनों, इनफैक्ट एग्जाम में आ चुका है, they had given this question in the exam, they asked you the therapy of choice and one option was ERP, the other option was CBT. What will you choose? You'll choose something more specific. ERP या CBT? Answer is ERP. If you have to choose an option, it should be more specific. The answer should be more specific. Yes, very good, everybody. ERP is the better answer. So this question was asked in FMG examination and in the NEET PG examination. As far as psychiatry is concerned, the questions that are being asked in FMG and NEET are almost same nowadays. Body focused repetitive behavior disorder. First of all, trichotillomania. What happens in trichotillomania? The patient has an urge to pluck or pick the hair. The patient has an urge to pluck or pick the hair. It could be on the scalp. It could be even the eyebrows. It could be even the eyelashes. So a hair is picked, the hair is picked or plucked, and some of them swallow the hair. So after picking, there may be actually trichophagy, swallowing. You swallow the hair. And if you continue swallowing the hair for a long period of time, all the hair that goes into the GI tract, it may form a ball of hair called as trichobezoar. So eating of hair, swallowing of hair is trichophagy, and then it may form a ball of hair in the stomach or small intestine, and it may cause actually the obstruction of the intestine. The patient may present to you with abdominal pain. And when the surgeon cuts open the stomach or intestine, what they find is a ball of hair. Trichotillomania. In excoriation disorder, rather than picking the hair or pulling the hair, the patient keeps on pulling on the skin. They keep on pulling on the skin, usually on the nail beds. And they injure their nail beds. Usually the fingers, the skin of the nail bed is picked, and they end up injuring all their fingers. Excoriation is picking of the skin. This was a image from FMG examination. Very simple question, but they gave this image. बताओ क्या आंसर है? बहुत ही सिंपल क्वेश्चन है. वॉश मी लिखा हुआ है. somebody is washing the hands. Of course, what is the answer? Answer is of course OCD. And ये भी FMG एग्जाम का क्वेश्चन था. A patient was operated for pain in abdomen and a mass of hair was removed by the surgeon. क्या है ये mass of hair? This is nothing but a trichobezoar. Patient probably has trichotillomania. And if the patient has trichotillomania, where will you refer the patient? Of course, to the psychiatrist. So these two MCQs were asked in the FMG examination. They can as well be asked in the NEET PG examination. In fact, I would say this was a very good question. चलिए बात करते हैं PTSD की. सबसे इंपॉर्टेंट पॉइंट, एक्सट्रीमली इंपॉर्टेंट, द बिगेस्ट मिस्टेक दैट यू गाइज मेक, just because history of trauma is given, don't make the diagnosis of PTSD. Just because history of trauma is given, do not make the diagnosis of PTSD. Right? एग्जाम में, अच्छा मुझे इसका आंसर बताओ. लेट मी मेक अप अ क्वेश्चन. 38-year-old female patient had an accident, and she had a bad road traffic accident, and in the accident she did not suffer any injury, but she was very shaken after the accident, and 3 weeks later she started developing symptoms of sadness of mood, lack of interest in work, negative thoughts, poor sleep and appetite. What is the most likely diagnosis? Option 1 PTSD, option 2 adjustment disorder, option 3 depression, और ऑप्शन 4 OCD. क्या आंसर है? मुझे नींद आ रही है. नहीं, मुझे नींद नहीं आ रही. क्या आंसर है इस क्वेश्चन का? जब से सेरिबेलम स्टार्ट हुआ तब से नींद वैसी कम आनी शुरू हो गई है. काम ही करते रहते. एनीवेज, हाँ, क्या आंसर है इसका? डिप्रेशन. ठीक है. Even if there was a history of accident, it does not mean that you will make a diagnosis of PTSD. डायग्नोसिस आप सिम्टम के बेसिस पे बनाएंगे, ट्रॉमा के बेसिस पे नहीं. ठीक है. सो फॉर PTSD, रिमेंबर दैट देयर शुड बी 3 symptoms. Patient had a traumatic event, there would be intrusion symptoms, avoidance symptoms, and arousal symptoms. What do we mean by that? So say I was driving in, say, Hyderabad. I was driving in Hyderabad, and say I had an accident. In the accident, I did not suffer from any injury, but I have developed PTSD. What are the symptoms that I will have? 6 months later, after the accident, sitting in Delhi, suddenly that whole image of a vehicle coming and hitting my vehicle may flash in front of my eyes, called as flashbacks. It may flash in front of my eyes. This is called as intrusion symptom. The images of that accident will flash in front of my eyes. Secondly, avoidance. Probably I would stop going to Hyderabad. Probably I would stop driving. I would avoid everything that reminds me of the trauma. And there would be arousal symptoms. I would have increased anxiety symptoms. This is what is called as PTSD. Right? And what is the treatment of PTSD? This question has been asked in the exam. What is the treatment of choice for PTSD? The answer is, the treatment of choice is cognitive behavioral therapy. And if somebody asks you what is the drug of choice for PTSD, the answer would be selective serotonin reuptake inhibitors. Both these questions have been asked. To make the diagnosis of PTSD, the symptoms must last for at least 1 month. Please remember, they may last for at least 1 month. ठीक है जी? All right. इसमें सोमैटिक सिम्टम में हम बहुत 2 बातें याद रखेंगे. आपको 2 डिसऑर्डर्स का नाम याद रखना है, सोमैटिक सिम्टम डिसऑर्डर और हाइपोकॉन्ड्रियासिस, जिसका नया नाम है इलनेस एंग्जाइटी डिसऑर्डर. वी मस्ट रिमेंबर 2 डिसऑर्डर, सोमैटिक सिम्टम डिसऑर्डर एंड हाइपोकॉन्ड्रियासिस और इलनेस एंग्जाइटी डिसऑर्डर. Most of you must have done your internships, or if you are doing your internship, you must have seen patients who come to the medicine OPD and they'll keep on, describing the complaints which are non-specific. The patient will come and say, I'm having gas in the stomach, gas in the abdomen, there is bloating, I don't feel good, there is indigestion, and you get all the tests done, but you'll find nothing. Everything comes out to be normal, but you feel that this patient is preoccupied with the symptoms. All he does is talk about his symptom. You ask him how is everything, he'll say everything is good, but there is gas in the abdomen. Then you ask him what are the future plans, he'll say how can I plan for future when there is gas in the abdomen. You ask him when are you planning to get married, he'll say how to get married when there is gas in the abdomen. No matter what question you ask him, his answer would be there is gas in the abdomen. So you feel that the patient is preoccupied with the symptom, a somatic symptom. This is somatic symptom disorder. Preoccupation with the symptom is somatic symptom disorder. Preoccupation with diagnosis. The patient is, ये क्या हुआ? Conversion कहाँ से आ गया? Preoccupation with diagnosis. The patient has a belief, or patient is preoccupied with the idea that he has a diagnosis. It is hypochondriasis. So if a patient repeatedly says that there is gas in the abdomen, there is bloating, there is indigestion, and you don't find anything in the investigations, it goes towards somatic symptom disorder. But if the patient continues to go from doctor to doctor and says, I have stomach cancer, I have stomach cancer, you get the investigations done, you reassure the patient, but the patient then goes to another doctor and says, I have stomach cancer, then it becomes hypochondriasis, right? Preoccupation with symptoms, preoccupation with diagnosis. This is important. Conversion disorder. In conversion disorder, patient presents with either a motor symptom, a sensory symptom, or seizure. So say the patient may present with the motor weakness of the upper limb. Right upper limb is, patient says there is weakness in the right upper limb. Or the patient may have sensory symptoms. Patient say that I cannot see from my right eye. Or the patient is having seizures. But when you do the investigations, everything comes out to be normal. Even when the patient is having seizures, if you do the EEG, there is no epileptic activity on the EEG. So symptoms are neurological, but the cause is psychological. Symptoms are neurological, but the cause is psychological. And that is why the symptoms do not follow the anatomical and physiological principles either. Say a patient comes to you and he says that I am having lack of sensation, lack of touch sensation in my hand. And then you try to map the lack of sensation. You know from the knowledge of anatomy that we have got one nerve supplying 1.5 finger, the other three remaining fingers, the third nerve supplying a part of the palm. But this patient comes and says that I have lack of touch sensation in the top half. This half does not have any sensation, and this half has complete sensation. So when this happens, you know that this is not following the principles, the anatomical principles, and that gives you a hint that probably it is conversion disorder. These patients also have what is called as labile indifference. They appear to be not concerned with their symptoms. The patient comes to you, the patient says, doctor, I cannot see with my right eye, but it's okay, it happens, chalta hai, koi badi baat nahi hai. The left eye is still there, not a big deal. So you are surprised that how can somebody be not concerned with lack of eyesight? This is labile indifference, lack of concern for the symptom. And one of the important differential diagnoses is acute intermittent porphyria, AIP. Important question. Alright, let's talk about the substances. Alcohol. What is the legal limit for driving in India? What can be the alcohol level till which you can drive in India? Alcohol levels, alcohol concentration. Legal limit कितना है बताइए? It is 30 milligram per deciliter. If you are caught driving beyond that, you can be arrested or whatever action the police wants to take, they can do that. Legal limit is 30 milligram per deciliter. Another important question, corresponding to what concentration of alcohol do we see alcoholic blackouts? What are alcoholic blackouts? You were drinking in the night and tomorrow or the next day you do not remember whatever you did. Say you were drinking and you were sitting with your friends and you made elaborate business plans. You made elaborate business plans with them. At that time you were looking totally in control. But the next day in the morning you have no idea what were those plans. You don't even remember what you were discussing. What would be the blood alcohol concentration that would correspond to this? 200 to 300 milligram per deciliter. Alcoholic blackouts are seen corresponding to 200, they correspond to 200 to 300 milligrams per deciliter. It's a type of anterograde amnesia. It's a type of anterograde amnesia. Yes, very good. Very important, lot of questions are asked from this topic, alcohol withdrawal. After 6 to 8 hours, we have tremors, which is the most common alcohol withdrawal symptom. And then you have all these nausea, vomiting, hypertension. After 24 to 48 hours, the patient may develop alcohol withdrawal seizures, which are usually GTCS, generalized tonic-clonic seizures. And after 48 to 72 hours, you may have delirium tremens, which is the most dangerous complication because it can be fatal. Delirium tremens. NEET में अभी क्वेश्चन आया था, sometimes a surgery or infection may trigger delirium tremens. A patient who has been using alcohol chronically may have delirium tremens which may be triggered by a surgery or an infection. Typical question क्या आता है? What is the typical question? This is the typical question. A 40-year-old person has been consuming alcohol for last 15 years. Because of religious reason, he stopped taking alcohol 4 days back. Now, the patient appears to be confused. Patient is not able to identify his family members. And the patient is not able to identify that he is at home, which means the patient is disoriented to place and person. And the patient is agitated. And the patient also says that there are small insects all around him. Small insects all around him. What is the diagnosis? Yes, this session would be available on YouTube. What would be the diagnosis? Delirium tremens. There are 3 symptoms of delirium, of all the deliriums. Delirium tremens is nothing but a delirium caused by alcohol withdrawal. हाँ जी भाई, आई अग्री, 2 year internship is injustice. जो भी लिख रहा है बार बार, आई टोटली अग्री विथ यू. डिलीरियम के देयर आर 3 symptoms. What are the symptoms? Disturbance of consciousness, disorientation to time, place and person, and usually visual hallucinations. This is delirium tremens. Important thing, whether it is simple tremor or whether it is highly dangerous delirium tremens, the drug of choice for all of them is benzodiazepines. You treat all the withdrawal symptoms of alcohol with benzodiazepines. INICT question 2022. If a patient has compromised liver function, which benzodiazepine would you prefer? If the patient has compromised liver function, you prefer benzodiazepines which are short acting. Which are those? Either oxazepam or lorazepam. Oxazepam or lorazepam. So drug of choice for the detoxification is benzodiazepines. What is the best anti-craving agent? Exam question. What is the best anti-craving agent for alcohol? बताओ. What is the cause of seeing small insects? It's visual hallucinations. What is the best anti-craving agent, most effective anti-craving agent for alcohol? Naltrexone. Preferred over acamprosate. Naltrexone preferred over acamprosate. What was the older method of treatment? Disulfiram. Older method was disulfiram. If a patient is on disulfiram and if he consumes alcohol, he will have a very unpleasant reaction, nausea, vomiting, hypotension. And the idea was that the patient would be afraid of this reaction and would not take disulfiram. But what patients do in reality, they continue taking alcohol and they stop taking disulfiram. That is why disulfiram does not work. You think that the patient would not take alcohol because he is afraid of the reaction that will happen after taking disulfiram, but the patient does the opposite. He takes alcohol, he stops disulfiram. That is why in real world this does not work. What works is this: if you can cut down on the craving, you can actually decrease the chances of relapse. ठीक है जी. Let's talk about opioids. What is the most commonly abused opioid? It's heroin. Most commonly abused opioid is heroin. Other are morphine and codeine. NEET 2022 question. Purser favorite metronidazole. हाँ. ठीक है. हेरोइन पैथो का सेशन कब है? पैथो सेशन नेक्स्ट वीक है. नेक्स्ट वीक है भाई पैथोलॉजी का सेशन. सर खुद आएंगे आप लोगों के घरों में पढ़ाने के लिए आपको, चिंता मत करो. हेरोइन होता है, हेरोइन नहीं होता. स्पेलिंग ठीक लिखो भाई. मोस्ट कॉमनली अब्यूज इज हेरोइन, नॉट हेरोइन. हेरोइन इज समथिंग एल्स. ठीक है. अगर ओपियोइड का ओवरडोसेज हो जाए तो इट कैन एक्चुअली बी लीदल. व्हाट इज द मैकेनिज्म ऑफ डेथ इन ओपियोइड ओवरडोसेज? एग्जाम में क्वेश्चन है. इट इज रेस्पिरेटरी डिप्रेशन. इन some states of India like Punjab and northeast, many deaths are seen because of the opioid overdosage, heroin overdosage. How does it happen? Respiratory depression. What is the drug of choice? This year question, you immediately give naloxone, opioid antagonist. You give naloxone. This year question. राइट. अगेन अ वेरी इंपॉर्टेंट क्वेश्चन, बहुत एग्जाम में क्वेश्चन आता है ये. गोविंद सर प्रणाम, लव यू टू सर. गोविंद सर आ गया हमारी क्लास में. हमारा तो वो बोलते हैं ना, वो जीवन सफल हो गया. चलिए, लेट्स टॉक अबाउट द विड्रॉल सिम्टम्स ऑफ ओपियोइड्स. So withdrawal symptoms are extremely commonly asked in the exams. So it presents like a flu-like syndrome. Patient has watering from everywhere. Patient has lacrimation. Patient has rhinorrhea. Patient has diarrhea. Then typically patient has yawning and piloerection. Goosebumps. Muscle ache. Body ache is severe. When we treat patients with opioid addiction, when they come for the treatment, this is what they say, that the pain is so severe that they cannot do anything. Sometimes you have to give, very high dosages of ibuprofen or other NSAIDs. The body ache is really bad. The good thing about the treatment of opioids is, for both the detoxification, as well as for the maintenance, for both of these, you use opioids only. For the detoxification of opioids like heroin or morphine, you use opioids like buprenorphine or even better, methadone. So for the detoxification of short-acting and parenterally taken opioids, you use long-acting orally given opioids. And not only for detoxification but also for maintenance, you use the same medications, methadone and buprenorphine, right? So this is something that you can remember, methadone and buprenorphine. If you have to pick one, you pick methadone. ये बहुत इंपॉर्टेंट क्वेश्चन है, हर साल आता है, पिछले 7 में से कम 5 साल तो आया होगा ये क्वेश्चन. ऑन टोबैको, व्हाट इज द ड्रग दैट वी यूज फॉर टोबैको सीजेशन? बताओ कौन सी ड्रग यूज करते हैं? वेरेनिक्लिन. They must have asked it at least 10 times by now. And what is the mechanism of action of varenicline? It's a alpha 4 beta 2 and alpha 7. It's a partial agonist at alpha 4 beta 2 and alpha 7 nicotinic acetylcholine receptor. It's actually a very effective drug. A lot of our patients who were not responding to anything, the older way was bupropion. I mean, one method is to use the patches and the gums, etc. But as far as the medications are concerned, we used to use bupropion, not so effective. When varenicline came in the market, it had worked like a charm. Many people who were not able to quit tobacco quit it very easily with varenicline. Unfortunately, it has been recalled from the Indian market. The Pfizer brought it by the name of Chempix, and there was some kind of contamination. Something happened that the Pfizer recalled it. So it's no longer available, but whenever it comes, it was a wonderful drug. Alright, let's talk about personality disorders. There are many personality disorders. We will talk only about two: antisocial PD and borderline PD. So they'll give you history of a person who does not follow rules or regulations, breaks the rules and regulations repeatedly, does not feel guilty, even when punished does not feel guilty. There may be substance abuse, history of substance abuse, does not take care of the rights of others. So somebody who breaks rules and regulations, even when punished, does not really feel guilty about it. Substance abuse is there, does not care about the feelings and rights of others. They ask you what is the diagnosis. The answer is antisocial PD. For example, say there is a guy who consumes alcohol, and after consuming alcohol he starts driving, and while drunk driving he kills people sleeping on the pavements of Mumbai, and then he goes to Rajasthan and he also kills some deer. What is the diagnosis? Batao. This is how you will remember antisocial PD. Jail history. Yes, jail history is also important. Just joking. But just remember that this is the history. Otherwise, अभी देखना कोई ना कोई पक्का गुस्सा हो जाएगा इस पर, मुझे लिखेगा, मैं कमेंट्स पढ़ ही रहा हूँ. आई एम जस्ट जोकिंग, आई एम जस्ट ट्राइंग टू मेक यू रिमेंबर, अदरवाइज आई एम ऑल्सो फैन ऑफ भाई, डोंट वरी. ठीक है. याद करने के लिए दे रहा हूँ. ठीक है, चलिए. बॉर्डरलाइन पीडी इज इवन मोर इंपॉर्टेंट फॉर योर एग्जाम्स. Borderline PD is even more important for your exams. You will be given history of a young female. They'll say that patient has emotional instability. There is emotional instability. The emotions change a lot. Typically, they say that the patient is very moody. The mood changes for no good reason. Everything is good, the patient suddenly becomes very angry, very irritated, very sad. There is impulsivity. The patient takes decisions without thinking about it, without thinking about the consequences. For example, life-changing decisions. The patient is living in one city, suddenly she leaves it and goes to some other city. The patient was doing, say, engineering, suddenly she quits in the second year and starts doing fashion designing. The patient was with one person, there was a boyfriend for 1 year, suddenly she goes into relationship with somebody else. So major life-changing decisions are taken impulsively. This is impulsivity. And for your exams, the most important thing is history of deliberate self-harm. The patient harms herself. Typically, the cutting of wrist. The patient cuts the wrist, right? Deliberate self-harm. This deliberate self-harm. What is deliberate self-harm? The act of harming self with the knowledge that, or without any intention of killing self. I'm harming myself, but I don't really intend to die, right? So this is the history that they gave you. Young female comes to emergency after self-harm. Similar history in the past. Patient is emotionally unstable. There's a lot of impulsivity, and they ask you the diagnosis, borderline PD. The commonest mistake that you make, you think that this deliberate self-harm is a suicide attempt, and you think it's a suicide attempt, so you make the diagnosis of depression, because the most common cause of suicide is depression. But if the history is given of years, long standing pattern, and then you are given history of impulsivity and emotional instability, in that case, please do not make the diagnosis of depression, make the diagnosis of borderline personality disorder. Munish Sharma, you are very right. Parasuicide is quite similar to deliberate self-harm. Chaliye, eating disorders. Let's call this girl A, this girl B, this girl C. According to you, which girl has normal weight, which one is fat, which one is too thin? Batao. Vanshika, it does not matter. If you want to become a psychiatrist, become a psychiatrist. Does not matter at all. Don't worry. Yes, you should. Batao A, B, C. Which one has normal weight? Which one is a bit fat? Which one is a bit thin? सब नॉर्मल कौन है इनमें से बताओ? बी नॉर्मल. बी नॉर्मल. बीच में सेरिबेलम एकेडमी, ज्वाइन अवर टेलीग्राम ग्रुप टुडे. प्रमोशन चलते रहना चाहिए साथ में. ठीक है. अब इंपॉर्टेंट चीज़ ये है कि हम लोग नॉर्मल और थिन और फैट किस बेसिस पे बोलते हैं. ऑन व्हाट बेसिस डू वी से दैट अ पर्सन इज थिन और फैट? वी हैव व्हाट इज कॉल्ड एज वी हैव एन इमेज इन अवर ओन हेड. गोविंद सर कह रहे हैं मेरे को तो ए भी नॉर्मल लग रही है. सर देखो 10:30 हो चुके हैं, अब आपको सब कुछ नॉर्मल लगेगा. सी भी मैंने कहा था ना, आपको सब कुछ नॉर्मल लगेगा. अच्छा चलिए पढ़ लेते हैं. सो ऑन व्हाट बेसिस डू वी कॉल अ पर्सन नॉर्मल और फैट और थिन? सो वी हैव एन इनर इमेज ऑफ व्हाट नॉर्मल शुड लुक लाइक, राइट? बॉडी इमेज. सो वी ट्राई टू मैच द इनर इंटरनल बॉडी इमेज विद द पर्सन. इफ इट मैचेस वी से नॉर्मल. इफ इट इज लेसर देन दैट वी से थिन. मोर देन दैट वी से इट इज द पर्सन इज फैट. गोविंद सर लव यू टू सर. ठीक है, तो B is normal weight, A is thin and C is fat, right? What if this body image is disturbed? What if there's a person for whom the normal corresponds to A? This person has a body image disturbance. The internal concept of what normal should look like is disturbed. So if this person's body image is corresponding to A, for this person what will happen? What will B be? B will become fat. C will become even more fat, super fat. This is what happens in anorexia nervosa. A girl who is normal, whose weight is normal, but who has a distorted body image. A normal girl looks at herself in the mirror. But what she sees is a fat girl because her body image is disturbed. And she tries to become normal according to her standard, which in reality is quite thin. This is called as anorexia nervosa. This is what happens in anorexia nervosa. So there's a disturbance of body image, disturbance of what normal looks like. And because the body image is disturbed, the person starts to try to become something which in reality is very thin. And how does the person do that? By restricting the energy intake. They try to cut down on the calorie intake. Even when they are very thin, they still have a very strong fear of getting fat. They are morbidly afraid of becoming fat. And finally, because of the loss of weight and because of calorie restriction, there are medical signs and symptoms of starvation, such as a very common one is amenorrhea. Right? Amenorrhea. Exactly. So nowadays we in the newer classification system of ICD, we say to make a diagnosis of anorexia nervosa, the BMI should be less than 18.5 kilogram per meter square. The BMI should be less than that. 18.5 kilogram per meter square. Only then you can make the diagnosis of anorexia nervosa. Now please remember, this is very important and this is a common mistake that you make. There are two types of anorexia nervosa. The first one is called as restrictive type. Restricting or restrictive type, where the calorie intake is restricted, as we just discussed. Other one is called as binging purging type. In binging purging type, patient usually does not have enough calorie intake, but there are times when the patient would binge on it. There are times. चले जाओ तुम, क्यों वेट कर रहे हो? हाँ जाओ बस जाओ. हाँ जी, MS is very right. Amenorrhea has been removed in ICD. So in restricting type, the calorie intake is restricted. In binge eating purging type, patient usually restricts the calorie intake, but there are episodes when patient will binge on food followed by purging. Patient will eat a lot of food and then will try to vomit it. The mistake that you guys make, you think that binging and purging are seen only in bulimia nervosa. This is not true. Binging and purging can happen also in anorexia nervosa. Please remember this. This is a common question and a common mistake. Sometimes if the weight is too less, say according to the height, the patient's weight should have been at least 50 kg, but the weight is less than 20%, or the weight is more than 20% lesser than what it should have been, which means the weight is less than 40 kg. In that case, you hospitalize the patient. If the weight has fallen by more than 20%, then you hospitalize the patient. In case there are electrolyte imbalances, you hospitalize the patient, right? So please remember this. What happens in bulimia nervosa? There are episodes of binging. In a binge episode, patient eats a large amount of food in a short duration of time, followed by purging. How is purging usually done? The patient puts 2 fingers in the mouth and tries to activate the gag reflex, tries to vomit it out, right? क्यों हंस रहे हो भाई आप लोग? अलीजे. हाँ. So binging episodes followed by purging behavior. What will happen if a person purges again and again? See, as I said, usually you put fingers in the mouth. If you keep on doing it repeatedly, the knuckles, they get injured against the teeth. And the knuckles will have calluses. There is callus formation on knuckles. The acid is coming repeatedly into the oral cavity. What will the acid do? It will damage your teeth enamel. There may be dental caries. Patient may develop parotitis. If you are vomiting again and again, there is loss of acid, it will cause alkalosis, and there is loss of potassium and chloride. So hypokalemic and hypochloremic alkalosis. Now please again remember, these are signs of purging. As I said, purging can happen in both anorexia nervosa as well as bulimia nervosa, right? So just on the basis of these signs, please do not make the diagnosis of bulimia nervosa, right? How do we differentiate between bulimia and anorexia? Primarily on the basis of weight. The weight in bulimia nervosa is usually normal, whereas anorexia nervosa weight is significantly lower. That is the main differentiating factor. There are other things also, but primarily you differentiate on the basis of weight. ठीक है, वेट के बेसिस पे डिफरेंशिएट करना है आपको. स्लीप डिसऑर्डर्स, हाँ, वेट के बेसिस पे डिफरेंशिएट करना है. BMI के बेसिस पे डिफरेंशिएट करना है. वेरी गुड. There are other differences also. Sexual development is significantly disturbed in patients with anorexia nervosa. In bulimia, sexual development is usually normal. Endocrine abnormalities are significant in anorexia, not so common in bulimia. Anorexia patients are very secretive, they don't accept treatment. Bulimia patients are more accepting of the treatment. But आपके MCQs में the most important thing is the BMI and the weight. ठीक है जी. Sleeping disorders. Before we talk about sleeping disorders, let's talk about REM sleep. We know that we have NREM, non-rapid eye movement sleep, and rapid eye movement sleep. ठीक है. What happens to the, sir, how many years of NEET, FMG and INICT PYQs to be done for NEET exam? At least 5 years. जितना कर लो उतना अच्छा है. And focus more on the NEET, less on the INICT for NEET. If you do not have time, if your preparation is going very well, then INICT also. If your preparation is not going so well, you don't have much time, ensure that NEET questions are covered from word to word. आप लोग आपस में मत चैट करो भाई, मेरे से पढ़ लो थोड़ा सा. सर थोड़ा थोड़ा हिंदी में बता दीजिए, अच्छे से समझ आएगा. यार ये बड़ी दिक्कत है, मैं हिंदी बोलता हूँ तो बच्चे बोलते हैं इंग्लिश बोलो, इंग्लिश बोलता हूँ तो बच्चे बोलते हैं हिंदी बोलो. चलो, but see, most of the students understand English, so let's stick to the English only. REM sleep. So first of all, what happens to the muscle tone in REM sleep? Muscle tone is usually decreased. Muscle tone is usually quite decreased except for the eyeballs. It is very difficult to wake up a person from REM sleep, right? Although the term deep sleep is used for NREM 3 and 4, but if we talk about the ease of waking up a person, it is very difficult to wake up a person from REM sleep also. And also in REM sleep, we see dreams. We see vivid dreams, right? We see vivid dreams. Now, what will happen? Just think about it conceptually. What will happen? Say a person who is awake. Usually what happens? When a person goes to sleep, he first goes to NREM 1, NREM 2, NREM 3, 4, then REM comes. Say a person is awake and suddenly REM sleep intrudes. The person is awake and suddenly REM sleep is intruding. What will happen? Since there is loss of muscle tone in REM sleep, this person who is awake, there would be sudden loss of muscle tone. Secondly, REM sleep is quite deep. So if you are awake, suddenly you go into something which is very deep sleep. You will feel as if you are having a sleep attack. What is sleep attack? An almost irresistible urge to sleep. Also from a awake state, you are going into a state where there are dreams. You may feel as if you are hallucinating. And what do we call the dreams that we see while, what do we call the hallucinations that happen while going to sleep? We call them as hypnagogic hallucinations. Remember, go is while going to sleep, hypnagogic hallucinations. And the hallucinations that occur while getting up from sleep are called as hypnopompic hallucinations. Govind sir is saying REM means remembered and REM means not remembered. So the dreams that we see in REM, we remember them. So remember it as REM, remember dreams, and REM is you don't remember the dreams. Thank you, sir. Now if a person is awake and if the person suddenly goes into REM sleep, this is what will cause narcolepsy. And the symptoms of narcolepsy you can easily understand on the basis of the characteristics of the REM sleep. What are the symptoms? Hypnagogic and hypnopompic hallucinations. ठीक है, hallucinations that occur while going to sleep. Cataplexy is loss of muscle tone. Sleep attack, an irresistible urge to fall asleep. And sleep paralysis. ये sleep paralysis क्या होता है? ये sleep paralysis happens in usually also in the so-called normal people also sleep paralysis may happen. Has it ever happened that you get up in the morning, you are awake but you are not able to move yourself, you are not able to move your body because there is no muscle tone? That is sleep paralysis. तो क्या करते हो उस केस में? If there is sleep paralysis, you get up but you cannot move yourself. There are two things: either you can wait for the muscle tone to come back, or more commonly you go back to sleep and think that next time we will wake up with the muscle tone, right? So sleep paralysis, these four things are seen in patients with narcolepsy. It is caused by reduced latency of REM sleep. It is considered as an autoimmune disorder associated with HLA class 2, and hypocretin is a neurotransmitter which promotes wakefulness. An autoimmune process destroys the neurons which make hypocretin, which results in narcolepsy. ड्रग ऑफ चॉइस क्या है भाई नार्कोलेप्सी की? बताइए ड्रग ऑफ चॉइस फॉर नार्कोलेप्सी? मोडाफिनिल. You also ask the patient to take regular naps. Ask the patient to take regular naps, but the drug of choice is modafinil. Hypocretin promotes wakefulness. ठीक है, सेक्सुअल डिसऑर्डर्स पे चलते हैं. सबसे पहले सेक्सुअल रिस्पॉन्स साइकिल. व्हाट आर द स्टेजेस ऑफ सेक्सुअल रिस्पॉन्स साइकिल? The first stage is desire. You have a desire to indulge in a sexual intercourse or sexual activity. Then there is excitement. What happens in excitement? There is penile erection. And there is lubrication of vagina. Among other things, vaginal lubrication and penile erection. And then there is stage of orgasm. And then the patient goes into resolution stage. The question in the NEET PG was, which is the shortest stage of sexual response cycle? Which is the shortest stage of sexual response cycle? Obviously, it is orgasm. The shortest stage of sexual response cycle is orgasm. Two more questions were asked from this topic. Hypnagogic समझ नहीं आया. Hypnagogic मतलब hallucinations that occur while going to sleep. जब आपको नींद आ रही है, when you are about to fall asleep, if at that time hallucination happens, it's hypnagogic hallucination. Hypnopompic is when you are getting up. आप जब जागने वाले हैं उस टाइम पे hallucination हो, then it is called as hypnopompic hallucination. Another question that was asked in the exam was, premature ejaculation is a disorder of which stage of sexual response cycle? Of course, orgasm. Erectile dysfunction is a disorder of which stage of sexual response cycle? Excitement. Raccoon medicose catalepsy is seen in schizophrenia, and in narcolepsy what we see is cataplexy, not catalepsy. Two important questions. चलिए, ये बहुत इंपॉर्टेंट क्वेश्चन है, एग्जाम में बार बार आता है. हाँ, हिप्नागोगिक को गोगा से याद कर लो. जब गोगा सोने जाता है, गोविंद सर ने नया निमोनिक बनाया बैठे बैठे यहाँ पे. गोविंद सर आप साइकेट्री आप ही पढ़ा लो, मुझे निकाल दो सेरिबेलम से आप. चलो, ये हम सबके पेट पे लात मारते हुए गोविंद राय गर्ग सर, ये ऐसे ही हैं. ये मेरे सीनियर हैं और ये पिछले, मैं इनको 15 साल से 18 साल से जानता हूँ, और ये 18 साल से मेरी रैगिंग बंद ही नहीं हो रही है, चली जा रही है. गोविंद सर इज अमेजिंग. ऑल ऑफ अस लव हिम. आई नो स्टूडेंट्स ऑल्सो लव हिम, टीचर्स ऑल्सो लव हिम, एवरीबडी लव्स हिम. फीस तो देते ही नहीं है. दिल्ली के 11 रुपये दिए थे और मुंबई के 21 रुपये दिए थे. सर हैदराबाद के कितने मिलने वाले हैं? देखते हैं. सर से मैं मांग रहा हूँ कि सर 25-30 तो दे दो. चलिए खत्म होने वाला है, आई थिंक 15-20 मिनट्स मोर. हाँ पोर्शा ले आए हैं हम. देखो हम डॉक्टर से तो सुना भी नहीं था पोर्शा क्या होती है. सर जब लेके आए तब तो हमें समझ आया कि पोर्शा को पोर्शा बोलते हैं. हमें तो प्रोनाउंस करना भी नहीं आता था. ₹1 देख रहे हो, ₹1 दे रहे हैं. ये पोर्शा वाले ऐसे ही होते हैं, दूसरों को ₹1 ₹21 ऐसे ही देते हैं. पोर्शा ऐसी ही खरीदी जाती है. अपूर्व मेरा सर प्रणाम नमस्कार. चलो सर मैं कोर्स तो ख़त्म करने दो, बच्चे कहेंगे ये लोग बातों में लग गए. ऑलराइट, सो दिस इज एक्सट्रीमली इंपॉर्टेंट. प्लीज रिमेंबर जेंडर डिस्फोरिया और जेंडर इनकॉन्ग्रुएंस. सो before we understand what is gender dysphoria, let us try to understand the difference between sex and gender. So when we use the term sex, we are primarily talking about the biological aspects, the anatomy. But gender is more of a psychological construct. Gender is what the person considers himself or herself to be. So usually a person with male organs would consider himself as a male. A person with female organs would consider herself as a female. But if the sex and gender does not match, it can cause gender dysphoria or gender incongruence. Right? So this is the difference. If a person with male sex organs, male anatomy, believes that she is actually a female and the person is distressed by it, then we call it gender dysphoria. Now, when gender dysphoria is seen in children, what are the symptoms? The child would prefer the dressing and activity which is associated with the opposite sex. Say the person is biologically a male, but the person prefers to dress with, say, frocks, likes wearing skirts or frocks and plays with dolls. This is what we mean by prefers the dressing and activity of the opposite sex. Sometimes the child says that he wants to be of the opposite sex. He wants to become convert into the opposite sex, or he wants to belong to the opposite sex. But because it's a child, the patient does not usually comment on the sexual organs per se, which changes when there is gender dysphoria in adolescents or adults. Now what happens? The patient clearly says that he is uncomfortable with the sex organs. For example, the patient would come and say that he does not like penis, he does not like his penis, he does not like his testicles, and he wants to change the sex organs. The patient comes and says that remove the penis, remove the testicles, and that he wants vagina and breast and wants to convert into a female. So this is the full-fledged form of gender dysphoria, where the person is uncomfortable with the sex organs and expresses the desire to change into to have the sex organs of the opposite sex. As far as your exams are concerned, please remember this phrase. The patient says that he is a man trapped in a woman's body, or a woman trapped in a man's body. The moment you see this line, what is the diagnosis? Gender dysphoria. Don't even think twice. Just write gender dysphoria. Right? Treatment. What can you change? You can change the mind of the person or the body of the person. Usually the body. Of course, Sunil, of course, we are not talking only about a single symptom. I mean, if a boy is playing with doll, does not mean that he has gender dysphoria, but we have to see everything in the perspective. There are many similar symptoms. If the symptoms persist, either you can give the hormonal treatment, or in some cases you can as well go for the sex reassignment surgery. You actually remove the penis, you actually remove the testes, you put some implants, make the breast, you can even make a false vagina. So this is what is called as sex reassignment surgery. Child psychiatry. Let's talk about ADHD first. Now the question that comes from ADHD, there are two types of questions. Yes, it can happen both ways. Female to male conversion or male to female conversion, both can happen. Right? Okay, let's talk about ADHD. There are two questions. The first question is on the diagnosis. The second question is on the treatment. Right? If you look at the name attention deficit hyperactivity disorder, the symptoms are in the name itself. Attention deficit or inattention and hyperactivity. So basically the history is the child is not able to give attention to the closer details. Child is not able to give attention to closer details. The teacher complains that child makes frequent mistakes. It is said that child cannot complete any task. He keeps on jumping from one task to another. Then there is complaint of hyperactivity. Hyperactivity. The child is hyperactive, does not sit at his desk, does not study and does not allow others to study, keeps on roaming in the class. And then there is impulsivity. The child is impulsive, cannot wait. If you are trying to ask a question from the child, even before you can complete the question, the child answers. So, inattention, hyperactivity, impulsivity. What is the drug of choice? Methylphenidate. You prefer the stimulants. Methylphenidate is the drug of choice. Right? Alright. Next is pervasive developmental disorders. The newer name is autism spectrum disorder. The most famous is autism, of course. Again, most of the questions from autism are clinical vignettes, clinical scenarios. They'll ask you to make a diagnosis. So there are three main symptoms. In fact, in the recent guidelines, one of these have been removed. But what are the main symptoms? Impairment in social interaction. The child has impairment in social interaction. How will it manifest? The eye contact is poor. You must have seen even little kids, infants, they make eye contact. Eye contact is poor. The eye contact is poor. As a child grows, not able to make friends because the social skills are not there. Not able to make friends. Sometimes we say there is no anticipatory posture. What is anticipatory posture? If you try to pick up a child, and if the child wants to come to you, he'll do this, right? He does something like this if he wants to come to you. If he does not want to come to you, he does this. So, this is anticipatory posture. When you want to pick up a child, if the child wants to come, he does this. This is anticipatory posture. He is anticipating to be picked. Then there is impairment of communication and language. Typically what we see is the other milestones are normally achieved, but the language milestones are delayed. Language milestones are delayed. And then we have what is called as restricted repetitive patterns of behavior. The same kind of behavior again and again, especially stereotypical movements. The child makes stereotypical movements. What are stereotypical movements? Spontaneous movements which do not serve a purpose. Like this is a stereotypical movement. It does not really serve any purpose. Yes. So what is the diagnosis? Autism. In last year they asked a question on Rett's disorder. Now Rett's disorder, the question that they asked was this only. Rett syndrome or Rett's disorder is almost always seen in female child. It's a very unfortunate disorder because for the first 5 months everything is normal. Everything is kind of normal. And between 5 to 48 months symptoms start to show up. There is deceleration of head circumference. What does it mean? The rest of the body continues to grow normally, but in comparison the speed of the growth of head is lesser. So the head keeps on becoming smaller and smaller in comparison to the rest of the body. This leads to microcephaly. Whatever hand movements the child had learned, whatever language the child had learned, all of that gradually the child starts to forget. And then the three symptoms of autism: restricted repetitive patterns of behavior, disturbed communication, lack of social interaction, all of those also start to show up. So most important thing as far as MCQs are concerned, females and microcephaly. Typically they give a question, all of the following are seen in Rett syndrome except, and one option is macrocephaly. So it's not macrocephaly, it's microcephaly. Mental retardation, the newer name is intellectual disability. What is MR? First of all, how do you calculate IQ? It is mental age divided by chronological age multiplied by 100. The normal IQ is between 90 to 110. Less than 70 is considered as mental retardation. Exam question. Varsha Chavda, treatment of autism. Difficult to treat, but it can be managed. Mostly special teaching, special schools, less of medications, more of all these things, occupational therapy, rehabilitation, these kind of stuff. What is the most common chromosomal cause of MR? कितना और है? 10 मिनट और है, ज़्यादा नहीं है, थोड़ा सा और हिम्मत रखो. What is the most common chromosomal cause of MR? Down syndrome, followed by Fragile X syndrome. Interestingly, more questions have been asked from Fragile X syndrome than the Down syndrome. ठीक है? Behavioral therapy, correct. Let's talk about psychoanalysis. Who is the father of psychoanalysis? This gentleman, Sigmund Freud. In fact, if you get a strange word in the exam, psychoanalysis, psychodynamic, any kind of strange word, and if they ask you about the father, mostly this guy is the father of all these things, Sigmund Freud, right? Sigmund Freud gave two kinds of theories. The first theory was topographical theory. According to topographical theory, Freud said there are three components of mind: conscious, preconscious, and unconscious. Whatever we know about us is conscious. Whatever you know about yourself is in the conscious mind. Things that you do not remember and you cannot remember, they are a part of your unconscious. And things which you can recall by putting some efforts, they are part of your preconscious. For example, if I ask you, try to remember the face of your 5th class teacher. Try recalling the face of your 5th class teacher. Can you recall her face? I'm assuming it's a her. Can you recall her face? If you can recall her face, it was in your preconscious. But if you cannot, it has gone into your unconscious. This is the topographical theory of mind given by Sigmund Freud. Later on, okay, so Freud said that there are many things which are hidden in the unconscious mind of the person. Many memories, many things are hidden in the unconscious mind of the person. Many things which are hidden in the unconscious mind of the person, which is causing psychiatric illness. And Freud said that if we can somehow bring these unconscious memories into the conscious, the psychiatric disorder would be treated. This is what he thought. And to do so, he gave a technique of free association. Who gave the technique of free association? Sigmund Freud. So in free association, basically what you do is you basically ask the patient to say whatever is coming in his mind. The only condition is that nothing should be censored. Whatever is coming in the mind, the patient should keep on saying without any censorship. This is called as free association. So when people freely associate, it is believed that unconscious content tends to slip out of the tongue. There are slip of tongue. There are slip of tongues which can tell you what is going on in the unconscious mind of the person. So this is called as free association. Sometimes when people are able to recall the unconscious memory, they are able to recall the memory that is associated with lot of emotional discharge. See, the patient was able to recall something which was very sinister, very sad, and suddenly he could recall it and now he is crying a lot. So recall of memory with emotional discharge. This is called as abreaction. id ego ये सब अलग होता है, बताएंगे अभी आपको. What is transference and what is countertransference? So the psychoanalysis treatment methods continue for years. During the process, the patient develops feelings for the therapist. This is called as transference. And the feeling that therapist develops for patient is called as countertransference. Transference and countertransference. It is actually used in the treatment. You don't need to understand what do we mean by these feelings. But just remember, patient to therapist transference, therapist to patient countertransference. Later on, at the age of around 80 years, Freud changed his theory. He gave a new theory. It's called a structural theory of mind. Now Freud said that there are three components of mind: id, ego and superego. Id is the component of your mind which basically consists of instincts, the desires that we are born with. The two main instincts are sexual instinct and the aggressive instinct. Ego is the part of your mind which works on a reality principle. Id works on pleasure principle. The part of your mind which wants to have fun, which does not care about the consequences, which wants to have fun right here, right now. It is id. Ego is the part of your mind which works on the reality principle. Superego is the part of your mind which works on morality principle. What is the meaning of this? So the part of your mind which wants to have fun right here, right now is id. The part of your mind which talks about morality, the part of your mind which tells you that always be honest, speak the truth, don't overspend, respect elders. All of this is superego. And who are you? You are egos. You are stuck in between these two. You know that too much of pleasure is also bad. You know that too much of morality is also bad. You know that in reality you have to make a balance. This is what is ego. For example, if you are following this live session for last 2.5 hours or 2 hours 15 minutes, your id is saying that all of this is nonsense. Let's throw the books away. Let's throw the copy away. Let's go to a pub. Let's get drunk. This is what your id is saying. Your superego on the other end is saying that let us listen to everything he's saying. Let me make the notes also, and let me also revise the notes today itself. And in between you are sitting, the ego is sitting, and you are trying to make a balance. You are thinking that if the session does not end in 15 minutes, I will shut down the laptop and I will watch a movie now. Too much of it has already happened. So you keep on making the balance. This is ego. Alright. To make this balance, ego uses certain defense mechanisms, which are called as defense mechanisms. Do you really want me to teach you defense mechanisms? They have not been asked for quite some time. टाइम बचा तो है नहीं, बहुत टाइम वैसे ही क्रॉस कर चुके हैं हम लोग. चलो 2-3 डिफेंस मैकेनिज्म्स में आ देता हूँ जो एग्जाम में आते हैं. फर्स्ट डिफेंस मैकेनिज्म इज व्हाट इज कॉल्ड एज डिस्प्लेसमेंट. वैसे भी इसकी अगली स्लाइड, आई थिंक देयर आर ओनली 2-3 स्लाइड्स लेफ्ट. डिस्प्लेसमेंट, व्हाट इज डिस्प्लेसमेंट? ट्रांसफर ऑफ इमोशंस फ्रॉम वन इंडिविजुअल टू अनदर इंडिविजुअल. फॉर एग्जाम्पल, say you go back to your home and your father scolds you badly for something and you get very angry, but you cannot say anything to your father. So what do you do instead? You go to the room of your younger brother and you start beating him. What have you done? You have displaced the emotion of anger from your father to your younger brother who is a softer target. ठीक है? Displacement. Humor. Use of comedy to deal with stressful situations. It's a mature defense mechanism. For example, you go for your viva. In the viva, both the internal and the external examiner get together and they humiliate you. They insult you. You get out of the viva room. You look at your best friend and both of you start laughing. You laugh as if something very funny has happened. You get insulted inside, you come outside, look at your friend and both of you start laughing. This is humor, very commonly used in medical colleges. Reaction formation. You do exactly opposite of what you wanted to do. For example, say Valentine's Day is coming. It's December, Valentine's Day is coming. You desperately want to go out on a date with a girl. But forget about going on a date. No girl is ready to even talk to you. So you are very frustrated. So what do? You arrange or collect or get into a group of people who are in a similar spot. 5-10 of you get together and then you make a party and then you say that Valentine's Day is against Indian culture, and you start beating those people who are going on a date. This is reaction formation. You do exactly opposite of what you wanted to do. Sublimation. Sublimation. अरे वैलेंटाइंस डे दिसंबर में नहीं आता, फरवरी में आने वाला है. इतना भी सच नहीं बोलना था भाई. तुम लोग किसी पार्टी वार्टी का नाम मत लो, तुम्हारा कुछ नहीं जाएगा. चलो, sublimation. What is sublimation? Sublimation में you have certain unacceptable impulses, but you kind of channelize them into acceptable behavior. You channelize unacceptable impulses into acceptable behavior. For example, you have lots of aggression. You like blood, you like flesh, you like violence, you like aggression, but all of that is unacceptable. So what do? You become a surgeon. Now you can play with flesh and blood, and it is also acceptable, socially acceptable. This is sublimation. Undoing. What is undoing? You try to undo a previous act. You try to fix a previous act. Undoing is done by all of us. This happens now if you happen to touch a book or pen by feet. If you step on a book or pen, you immediately start doing this, right? This is nothing but undoing, because you think that the moment you stepped on a book or pen, now the God will punish you, and you think by doing this, now the God will forgive you. This is undoing. All of us do it. You don't even realize that you have been doing so. So these are some of the common defense mechanisms. Let's talk about, I think 2 slides are left. Let's talk about Mental Health Care Act 2017. Croatia, awesome. Vivek sir, क्या हो गया Croatia को? Did they win? अच्छा, very good. Croatia defeated whom? सर अब सेरिबेलम ऐप निकाल दो, राह नहीं देख सकते. और बेटा प्लीज़ आस्क विवेक जैन सर एंड गोविंद राय गर्ग सर, दे आर द बॉस. हम तो छोटे लोग हैं. विवेक सर, बच्चे कुछ पूछ रहे हैं. ब्राज़ील आउट ऑफ टूर्नामेंट. अरे तो दुख की बात है. डोंट वी सपोर्ट ब्राज़ील यूजुअली, वी इंडियंस. गोविंद सर आ गए. गोविंद सर, बच्चे कुछ पूछ रहे हैं. क्रोएशिया बीट ब्राज़ील. I think we used to support Brazil. चलिए, there are only 2 slides left. Let's complete it. Mental Health Care Act. In 2017, the government of India passed Mental Health Care Act. The Parliament passed Mental Health Care Act, and it came into being. It came into force. A couple of things that we must remember about MHCA 2017. Advance Directive. According to MHCA, so anybody, for example, today I can write on a piece of paper that tomorrow if I develop a psychiatric illness and if I lose the capability of taking mental health care decisions for me because of the illness, the way I want to be treated and the way I do not want to be treated, I can write it on a piece of paper and I can submit it on the government website. Later, if I actually develop a illness, say I develop schizophrenia 5 years from today, and I lose the capability of taking decisions, that piece of paper that I had submitted, the treating psychiatrist should follow it. For example, today if I on a piece of paper write that if tomorrow I develop schizophrenia and I lose the capacity to take mental health care decisions, you can treat me with antipsychotics, you can also admit me, but you cannot give me electroconvulsive therapy. Say if I write this, 5 years later I actually have schizophrenia, I lose the capability. Now if the treating psychiatrist has shown the advance directive, he'll have to follow it. He cannot give me ECT. This is what is called as advance directive. Nominated representative, I can nominate a person who will take decisions on my behalf or who will help me in taking the decisions. Say I write that tomorrow if I develop schizophrenia, my wife can take decisions for me. So whatever my wife tells, the doctor will have to follow it. We talked about it already. Direct ECTs have been banned in India. ECTs in minors have been banned. You cannot give ECT in less than 18 years of age. If you want to give ECT in less than 18 years of age, you will have to take a special permission from what we call as MHRB, Mental Health Review Board. suicide has been decriminalized in India. Earlier there was a section, in fact there's a section IPC 309, according to which if you attempt suicide and if you survive, then you are punished for it. It was so stupid. Now it has been removed. MHCA has decriminalized the suicide. If somebody attempts suicide, it is assumed that the person was under a severe stress and no action can be taken against that person. Yes, Mental Health Review Board. And this question was asked in the INICT exam. The maximum duration of voluntary admission is 30 days. If you think that you have a psychiatric illness, and you want to get admitted, you go to a hospital, your psychiatrist also thinks that you need admission, and in case you get admitted, you can stay there only for 30 days. Chaliye, let's come to the last slide. Organic mental disorder. We have already talked about delirium. So we said that there are 3 important symptoms of delirium. First is disturbance of consciousness. When they give you a question on disturbance of consciousness, they usually say that the patient appears to be confused. In your wards, you must have seen the residents say that the patient presented with a altered sensorium. All these terms, altered sensorium, confused, all of them mean that there is disturbance of consciousness. Secondly, there is disturbance of, there is disorientation to time, place and person. The patient does not know what time it is. The patient cannot identify the place. In the exam they will say the patient was in hospital but he thought that he was in a jail. Patient cannot identify the person. The patient is not able to identify the family members. And the third symptom is usually visual hallucinations. So a typical question is, a 45-year-old male fell down from the bed and had dislocation of the hip joint. The patient was admitted in the orthopedic ward and he was operated upon. 3 days after the operation, after the surgery, patient suddenly appears confused and agitated. He cannot identify his surgeon, his orthopedician. He thinks that he is in a jail while he was in the hospital room and he does not know what date or time it is. And the patient also reports that there are small elephants playing piano in his room. What is the diagnosis? The diagnosis is delirium. This is a typical question that is asked in the exams. So this is about it. I think we covered most important things, most important points, and the questions that have been asked in the last couple of years. Bas, this is it. ठीक है जी, डन. साइकेट्री कंप्लीट इन 90 मिनट्स तो नहीं हो पाई. साइकेट्री कंप्लीट इन 145 मिनट्स. सर डोंट रिमूव दिस कंटेंट. ओके मैम, आई थिंक दे वोंट रिमूव दिस कंटेंट. सर डोंट रिमूव दिस कंटेंट. ठीक है मैम, नहीं करेंगे. सर मेडिसिन MCQ एंड पैथो सिस्टमिक का रिविजन करा दो प्लीज़. स्पर सर कराएंगे. अपूर सर थैंक यू. गोविंद सर थैंक यू. Thank you dear guys. Thank you Sushmita. Thank you Manish. Vivek sir, thanks a lot. Thank you. Thank you everybody. Thank you Shivani. Thank you Amit. Thank you Mohammed Sarwar. Thank you Shubham. अब जो लोग मुझे कुछ ख़राब भी बोल रहे हैं मैं उनको भी थैंक यू बोल दूंगा. मैं पढ़ नहीं पा रहा हूँ. Thank you everybody. All right. So guys, I think we'll continue doing this on our Cerebellum YouTube channel. Next week, Spur sir is coming, then Dilip sir would be coming, and we'll ensure that we keep on providing you the content, the important content that is important for the examination. And हम लोग लगे हुए हैं यार, हम लोग दिन रात लगे हुए हैं. Our entire life is around Cerebellum nowadays, and similarly your entire life should be around the NEET PG examination and the FMG examination which is coming. Let's study very hard. एंड लेट्स टेक द प्रिपरेशन टू द लास्ट डे. और अगर आप लास्ट डे तक पढ़ाई कर लेते हैं तो आपका सिलेक्शन हो ही जाता है. ये देखा है हमने. ऑलराइट गाइस, थैंक्स अ लॉट. गुड नाइट. थैंक यू. थैंक्स अ लॉट एवरीबॉडी. थैंक यू. गुड नाइट.